This is a lengthy chapter about renal disorders, so lengthy actually that I took out and we'll have a separate lecture for acute kidney injury and chronic renal failure. Kidneys start developing in the 5th week of gestation, and they actually will function in utero around the 8th week. And even producing urine around 9 to 12 weeks of gestation. And actually, urine is the main component of amniotic fluid. So if you think about that, a lot of people don't even realize they're pregnant at that time. So just to kind of show you a little bit about how that works. Some issues that may occur: renal hypoplasia is when the kidneys don't develop to a normal size. Hypo, of course, being less than, and cells, of course, plasia. Dysgenesis would be a failure of the organ to develop normally, not just in size but in function. And agenesis would be a failure of an organ to develop, and a lot of people will sometimes only have one kidney. Most kidney abnormalities involve shape and sometimes position. One of the most common, and the picture that I have here, is the horseshoe kidney, where your upper or maybe the lower poles of the kidneys are fused together, making it look like a horseshoe. And you can see these are the lower poles that are fused together on this particular person. And then that's a great picture there of the bladder. Okay, starting out with urinary obstructive disorders, they can occur in anybody at any given age and can occur at any level of the urinary tract. It can be, you can have an obstruction in the renal pelvis, you can have an obstruction in the bladder, in the urethra, in the ureter. It can be anywhere along the urinary tract. Some causes of obstructive disorders: renal calculi, aka kidney stones, which is your most common cause. Pregnancy, just from the buildup of fluid, and then the baby, of course, in the uterus, pressing on maybe the ureter and causing obstruction. Tumors could do the same thing. Benign prostate hyperplasia in your older men. The prostate sometimes can be so enlarged that it squeezes the ureter and they're not able to urinate. Ureteral stricture, where there's a narrowing of the ureter, or then just some congenital defects that people are born with. Of course, the most common cause of urinary tract obstruction is renal calculi or stones. The medical term for that is nephrolithiasis. What happens here is crystalline structures that should be excreted in the urine actually build up and form stones. The etiology is complex and really not truly fully understood. There are 3 theories of stone formation: saturation, matrix, and inhibitor theory. The only one, and the one that makes the most sense, is the saturation theory, where urine becomes supersaturated with stone components like calcium salts, uric acid, calcium oxalate, cysteine, and the greater the number of ions or concentration of ions that you have, the more likely they are to combine together and form a stone. There are 4 types of renal calculi or kidney stones. That's a pretty big one there in the picture. Calcium stones, magnesium, ammonium stones, which is cut off there by my picture. I didn't realize that. Those are also referred to as struvite stones, uric acid stones, and cysteine stones. Calcium stones are your most common. They account for about 70 to 80%. They're formed from different types of calcium. Some are calcium oxalate, some are calcium phosphate, some may have a combination of both. Usually associated with increased levels of calcium in the blood and, of course, in the urine. Your magnesium ammonium phosphate stones, referred to as struvite and staghorn stones, also usually only form in the presence of alkaline urine, and usually only in the presence of a bacteria, because that bacteria will release an enzyme called urease that splits into ammonia and carbon dioxide. That ammonia causes the urine to become more basic or alkaline, and allows the stone to grow and actually become very large. And they call them staghorn stones because they can actually have like little fingers, little prickly points that actually cause even more pain than your normal stones would. I want to go back here. I'm sorry, I know I keep jumping back and forth, but I wanted to add a little bit about the diet and let you know that there are, and in your book it goes into detail about certain foods and drinks and things that that put you at risk for kidney stones. And actually, I had a urologist tell me one time that the South was a urologist's dream of a job because we drank so much sweet tea, and tea actually increases your risk for kidney stones. So anyway, go. Signs and symptoms of renal calculi, what you see, what they feel. Pain is the big thing. Pain, pain, pain. And they actually refer to it as renal colic. Colic because it comes and goes in waves, like a baby that has colic. This is your most common manifestation here. Acute, intermittent, excruciating pain in the flank and upper outer quadrant of the abdomen that may radiate down to the groin. It may even actually radiate even lower, associated with some nausea and vomiting. That is the most common type of pain. Again, comes in waves, but is very excruciating at the time. Some people have non-colicky pain, and actually just have a continuous deep dull ache in their flank, and actually it gets worse when they drink fluid. So the majority of the people who have kidney stones have severe pain, but there are those few out there who will have a non-colicky type pain. Kidney stones may cause obstruction. That's really going to be the worst thing. Well, at the time, the people are going to think that the pain is the worst thing. But really what you're worried about is the stone causing an obstruction. Now just think, if you have a stone that is obstructing somewhere, urine flow somewhere in your urinary tract, then there's going to be a portion of the urinary tract that has a stasis of urine, where the urine actually is stopping because it's not able to pass through. Anytime you have a stoppage of anything, whether it's urine, blood, whatever, you have to worry about the risk of infection. And with the urinary tract, you have to worry about one other problem called hydronephrosis. Hydronephrosis is a urine-filled dilation of the renal pelvis and the calyces, and it actually will cause atrophy of the kidney because of impaired urine flow. If not treated, and if you don't remove the stone and repair the hydronephrosis, then the kidney will actually eventually be destroyed, and the patient will have pain and difficulty voiding. And you can see here in the picture your normal urinary tract there, anatomy. The first picture is mild hydronephrosis. You can see a little bit of dilation of the renal pelvis and the calyces there, but of course much more with the moderate and the severe. And the kidney actually around the renal pelvis and the calyces actually start to get smaller or atrophy. To diagnose and treat renal calculi or kidney stones, most of the time people will have an ultrasound or a CAT scan, and you can usually see it on CAT scan. Actually, usually better on CAT scan than you can on an ultrasound. Treatment, supportive care. They want pain medicine, I can tell you right now, especially if they have the colic type pain. Pain medicines, IV fluids. They're going to try to flush that stone out if possible. They also will want to strain the urine because they want to catch the stone or stones, if possible, so that they can analyze them and show and determine exactly what type of stone it is, so that maybe if it's diet related, they can prevent having future stones. If they're not able to flush the stone out, depending on where the stone is in the urinary tract, they may actually go up in the ureter and in the urethra and up into wherever the stone is and perform a lithotripsy, which is where they actually crush the stone to remove it. Okay? Urinary tract infections are the second most common bacterial infection that we see patients come in with. Some are symptomatic, some are asymptomatic. UTIs can affect the lower urinary tract or the upper tract. Excuse me. When patients have lower urinary tract infections, we refer to that as cystitis because it's more of a bladder infection. If it is truly a kidney infection or an infection of the upper urinary tract, we refer to that as pyelonephritis. Most UTIs are caused by bacteria that enter through the urethra. Of course, women are the ones that are most commonly affected by UTIs. Also, if someone has a kidney stone, you have to worry that if it obstructs the urinary tract, they may have stasis of urine and become infected with a bacteria. The most common bug that we see that causes UTIs is E. coli. We also see a lot of people who are hospitalized become infected with urinary tract bugs after they've had the insertion of a Foley catheter. For those who are in nursing school, there is a specific way and a sterile technique to insert Foley catheters so that bacteria does not get into the urinary tract, and that is very, very, very important. Good hand washing and sterile technique is very important to prevent a UTI. Clinical manifestations of lower urinary tract infections depends on if it's acute or chronic. Most people describe frequency, urgency, and dysuria, meaning that they have difficulty voiding, they feel like they need to go all the time, and when they need to go, they really have to go right then. A lot of the times they'll have thick, cloudy, foul-smelling urine, maybe even lower back or lower abdominal pain. Usually, though, with a cystitis or a lower urinary tract infection, there is no fever. Pyelonephritis is a different story. This is an inflammation of the kidney. It can affect all areas of the kidney, the tubules, the renal pelvis, and calyces, and the interstitial tissue. It can be acute or chronic. Acute pyelonephritis is the one we'll focus on, and it's caused mainly by bacteria, viruses, or a fungus. The most common bug for acute pyelo is E. coli. It usually results from a UTI in the lower tract that works its way up to the upper urinary tract. Some contributing factors are catheterization, somebody who's had a Foley catheter inserted, pregnancy, very common in pregnancy, people who have reflux of the bladder where they may not empty their bladder, or urine may not completely flow out of the kidney, or either it flows out and then it backflows or refluxes up into the kidney, and then neurogenic bladder. Clinical manifestations of acute pyelonephritis usually comes on very sudden, very rapidly. Chills, fever, headache, back pain, costovertebral angle tenderness, which I have a picture in the next slide, difficulty voiding or urinating, frequency, and urgency. And this is a picture that shows exactly where the CVA is, or the costovertebral angle is, when people have true kidney infections or pyelonephritis, where they will usually complain of pain. Okay, treatment, antibiotics, fluids, it has to be treated. If not, these people may develop sepsis or get that same bacteria in their bloodstream and actually go into kidney failure. They're usually very, very sick. Okay, moving on to glomerulonephritis, which is an inflammation of the glomerular structures. This is one of the leading causes of chronic renal failure in the United States. Some people have primary glomerulonephritis, where that is the only disease present. Some have secondary, which means it's just the result of another disease process. Most primary and some of your secondary cases of glomerulonephritis are actually immune responses. And if you remember back to the immune chapter, or when we talked about disorders of immune function, we talked about the 4 types of hypersensitivity responses. And remember, glomerulonephritis is a type 3 hypersensitivity response, meaning that it is one of those antigen-antibody complexes that floats around and then will cause damage to the tissue where it settles. And a lot of those go to the glomerulus and settle in the glomerular membranes, which leads to glomerular dysfunction and eventual kidney injury. Clinical manifestations of glomerulonephritis, just think about your kidneys not working, sudden edema or swelling, oliguria, meaning that they have a decrease in urine output, usually below 400 milliliters of urine output a day, less than that. Hematuria, which is blood in the urine. Proteinuria, which is protein in the blood. And high blood pressure. I'm sorry, I think I said that wrong. Hematuria is blood in the urine. Proteinuria is protein in the urine. And I think I said it was in the blood. I apologize. And then high blood pressure. And you can see here on my picture an ankle, and then somebody with glomerulonephritis or kidney disease that has mild edema, and then on to chronic kidney disease and the edema that you see there sometimes. Cellular changes that happen with glomerular disease, you see proliferative changes where there is an increase in the cell components that are there in the glomerulus. Then you will probably have sclerotic changes where there's an increase in collagen there in the glomerulus, and then membranous changes where there is an increase in the thickness of the capillary membrane or the capillary wall. With nephrotic syndrome, we see an increase in the permeability of the glomerular capillary membrane. Remember what permeability means. If there's an increase in permeability, then more substances are able to move back and forth across the membrane. With this, you actually lose massive amounts of proteins, mainly albumin in the urine. And albumin is very important in maintaining fluid levels and maintaining that protein in the body. Hyperlipidemia usually occurs because the liver is trying to compensate for the loss of proteins by making more lipids. I know it doesn't sound reasonable, but that is exactly how the body tries to adapt. And the hallmark symptom of nephrosis is generalized edema. They are just swollen all over their body. Polycystic kidney disease is an autosomal dominant genetic disorder. It's the number 1 type. And with polycystic kidney disease, you have filtrate-filled cysts that accumulate in the kidneys and press on the kidney tissue and cause damage. Cysts can actually develop blood vessels. Those blood vessels can rupture and actually cause people to have blood in the urine or major hematuria. And you can see here a normal kidney versus one kidneys with cysts there. You can imagine how that would affect kidney function. Renal cell carcinoma or kidney cancer is not very common, and normally those people who develop renal cell carcinoma have a family history of kidney cancer. There are some genetic components there that they have found. Some other links or risk factors include smoking, hypertension, polycystic kidney disease, obesity, and then exposure to asbestos, other herbicides and solvents, things of that nature. And actually smoking, they think, is responsible for 1/3 of the cases and actually doubles your risk of renal cell carcinoma.